Hey everyone, Chris here from MedPrep to Go, and I wanted to tell you about our MedPrep to Go Step 3 review podcast that features over 90 episodes and 40 hours of high-yield content from Dr. Ted O'Connell and Dr. Raj Dasgupta. This is a premium podcast that has already helped over 100 students pass their exam. You can learn more and subscribe at medprep2go.com. Hey everyone, Chris here from MedPrep to Go, and I wanted to let you know about our premium Step 2 Bundle podcast, which gets you all of the Step 2 secrets and our Step 2 Questions podcast combined and ad-free. You'll also get early access to all of our Step 2 Questions episodes before they're released public. The bundled podcast is available now, and you can save over 40% with an annual plan. Details at medprep2go.com.
Hey everyone, I'm Dr. Raj, and welcome to the MedPrep to Go podcast. So MedPrep to Go is a mission to improve medical student wellness and reduce educational debt by providing high-quality USMLE question bank in an online and audio format, by making medical education material available to study on the go. We strive to give you time back in your day to focus on your health and well-being. And this podcast was developed by Dr. Ted O'Connell and myself. I'm a quadruple board certified doctor in pulmonary, critical care, sleep medicine, and internal medicine. I've been teaching USMLE, for almost ever. And I teach step 1, 2, and 3. But today we're going to be going over step 2 questions. In fact, we're going to go over 3 questions today. And I'm super pumped. Why? Today's questions are about the heart. And you know, when it comes to cardiology, that's always going to be high yield for step 2. So let's get started. Ready? And if you want to follow along, go to the MedPrep to Go website and check out these questions. So first question is, a 17-year-old boy presents to his primary care physician to discuss shortness of breath while playing basketball. Stop right there. What's wrong with this statement? Oh, you nailed it. 17-year-old, whether you're a boy or a girl, you shouldn't be having shortness of breath. That's weird. You know what's not on the differential? Congestive heart failure. You know what's not on the differential? COPD. So something funky is going on here. All right. So, and he got it while playing basketball. So, of course, you test takers out there, 17-year-old playing basketball, chest pain, shortness of breath. I already know what you're thinking. I don't want to give it away, but someone just yelled out the word HOCM, hypertrophic obstructive cardiomyopathy. I'm not saying it is or isn't, but I know you thought about it. Okay, so back to the question, which has worsened over the past few years. Past medical history is non-contributory, and he takes no meds. Family history significant for the sudden death of the patient's father, who was healthy, and the father passed away at 36. So this is already making me tear up. What a sad vignette. Physical exam reveals a cardiac murmur. ECG reflects normal sinus rhythm with left axis deviation. So what can cause that? Left ventricular hypertrophy. I'm just throwing it out there. An echocardiogram confirms the presence of LVH. Which of the following findings is most likely present on physical exam? Is it A, crescendo, decrescendo systolic murmur at the right upper sternal border? B, crescendo, decrescendo systolic murmur at the left lower sternal border? C, decrescendo diastolic murmur at the left upper sternal border? D, mid-systolic murmur with a wide and fixed S2 splitting? E, soft and delayed aortic component of the S2. Wow, I really like these choices. So I think it all comes down to what we're talking about. What do you think the diagnosis is going to be? And really, it jumps out to be HOCM, hypertrophic obstructive cardiomyopathy. Think of the classic HOCM, where you have this really thick septum. And when I teach heart murmurs for the USMLE, of course, we think that, the heart murmur of HOCM, somewhat, and now let me take that back. I would say when I think about the physiology of HOCM, it's a little bit like when we're talking classic HOCM with the big septum, kind of like aortic stenosis, But of course, bear with me when we talk about manipulating that murmur by increasing and decreasing venous return. Of course, it's going to be a little bit different. So if I choice A, decrescendo systolic murmur at the right upper sternal border, that is the classic aortic stenosis. Whether it's going to be aortic stenosis from calcifications in old age, whether it's going to be a bicuspid aortic valve, that's the classic location. Now, B, decrescendo systolic murmur. Well, hey, that is something that we do, here with HOCM, and the location is much better. It's the lower left sternal border. So I like that. B makes sense to me. D, decrescendo diastolic murmur, left upper sternal border. Well, that's kind of like aortic regurgitation, that diastolic rumble that you could hear. So I'm not going with C. The mid-systolic murmur with the wide and fixed S2 splitting. Well, when you talk about fixed splitting, what does that mean? It really means whether you're taking a breath in or taking a breath out, that the pulmonic valve will always close second before the aortic valve. And when do we classically think about this? Yeah, when you have this atrial septal defect, ventricular septal defects, which is not this. A soft and delayed aortic component of the S2. So that's kind of talking about what we refer to as a paradoxical splitting. So when we have physiological splitting, that means when I take a breath in, that the pulmonic valve will close second, and the aortic valve will close first. When you have a delayed aortic component, that's what they call paradoxical splitting. We do see that with aortic stenosis, in the sense that because it's very stenotic, the aortic valve will close second. But this is HOCM. So I want to choose B as my answer over here. Let me check the answers. All right, we're on the same page. This patient has HOCM. And the answer is, this is classically seen in people have a family history of sudden cardiac death. The murmur may radiate to the axilla and base, but usually not to the neck. Pathogenesis is related to the asymmetrical ventricular hypertrophy, reflected by a left axis deviation on ECG. Treatment is with beta blockers initially, calcium channel blockers if you don't tolerate beta blockers. Definitely in people who've had, unfortunately, an episode of syncope, you definitely want to consider putting a ICD into these patients, which is intracardiac defibrillator. Choice A, decrescendo systolic murmur at the right upper sternal border is incorrect. As I said previously, we see that with aortic stenosis. Choice C, with the decrescendo diastolic murmur at the left upper sternal border, once again, incorrect. Like we mentioned, think about aortic regurgitation. Choice D, the mid-systolic murmur with the wide and fixed S2 splitting, as I mentioned prior. Think about ASD and VSD. And last, choice E, soft and delayed aortic component of S2 is incorrect. And that's usually what I was mentioning earlier, something we see with aortic stenosis. Think about that paradoxical splitting. So what is the key learning point here is that hypertrophic cardiomyopathy often presents with dyspnea in patients who have a family history of sudden death in a young individual. Think about the asymmetric ventricular hypertrophy that may present as left axis deviation on ECG. Physical exam may reveal a decrescendo systolic murmur, best heard at the mid-left sternal border, which is in contrast to the murmur of aortic stenosis, which is best heard at the right upper sternal border. And remember, unfortunately, these individuals, if they have HOCM, they cannot play sports. It hurts me just to say it. And you don't give them beta blockers or ICD or any other therapies in order to play sports. These individuals cannot play, unfortunately, these very aggressive contact sports. So that's also a key thing for the board exams. Let's do another one. What about this 50-year-old woman presents to the clinic after a high blood pressure reading of 165/85. At the health fair, past medical history is significant for hypothyroidism. She takes levothyroxine. She does not smoke cigarettes or drink alcohol. She walks 30 minutes every day. Her father died at age 70 from an MI. Her blood pressure at this visit is 150/90. She has a body mass index of 26. Physical exam is unremarkable. She's instructed to measure her blood pressure at home, and over the next 2 weeks, confirms that her blood pressure is consistently elevated. Which of the following is the most appropriate next step in the management of this patient? Is it A, 24-hour urine cortisol and plasma fractionated metanephrines? That seems to be no. That's a little overkill right there. 24-hour urine cortisol, it's screaming more of like a Cushing's type workup. I'm not really feeling this through the vignette. And plasma fractionated metanephrines, you know what I'm thinking about. Say it. That's right. Pheochromocytoma. I don't feel anything that screams pheo in this case. Choice B, echocardiogram, hemoglobin A1C, a TSH, and urinary albumin to creatinine ratio. These are not bad things to get. And don't get me wrong, in real life, some people might get this. But, this answer, I could tell, was written per the guidelines of what would be, what would you work up first in someone who has difficult controlled hypertension if there was any obvious signs or symptoms pointing you in one specific diagnosis. And echo is not part of that. I think echo is one step extra. Ordering an albumin creatinine ratio. I love that in diabetics to make sure they're not spilling albumin in the urine. But once again, I think those things are going to take it one level extra. So let's choice C, getting ECG, love a CBC, TSH, which is thyroid stimulating hormone, chemistry panel, lipid panel, and urinalysis. That seems really basic. And that's things that I would probably do. So I'm feeling C right now. Let's look at choice D. Plasma renin activity, fractionated metanephrines, aldosterone levels. That's screaming a Conn's syndrome, a primary hyperaldosteroid. Nothing really screams that over here. So I probably wouldn't do D. E, renal ultrasound and MRI of the renal arteries. Give me a Brewy, give me something to make me feel it's renal artery stenosis, like place me on an ACE inhibitor and all of a sudden things get really bad when it comes to my kidneys. But no, I think just judging by the answer choices, I'm going to go with choice C. Let me hit the button here. All right. Choice C is correct. It is the initial evaluation of hypertension directed at the underlying complications of hypertension or comorbid conditions that may influence management. Baseline assessment should include serum chemistry panel, which is the electrolytes, fasting blood glucose, and serum creatinine, a hemoglobin and hematocrit, a UA to exclude hematuria and to evaluate for proteinuria, an ECG to screen for LVH or prior MIs. Some experts advise measuring serum TSH because thyroid disorders are common and increase the risk for hypertension. In addition, patients with hypertension are at increased risk for ischemic heart disease and should be screened for other major atherosclerotic risk factors. Therefore, a lipid panel is recommended. And patients should also be screened for diabetes with either a fasting blood glucose, which may be obtained as part of the standard serum chemistry panel, or a hemoglobin A1C. Answer choice A is wrong. 24-hour urine cortisol and plasma fractionated metanephrines is, in this case, you're thinking more of a Cushing's syndrome, which nothing indicates Cushing's syndrome here, whether it's be physical findings, early onset of diabetes, early onset of osteoporosis, pheochromocytoma. Give me some buzzwords: episodic, headaches, weight loss, abdominal pain. So I wouldn't do A in this case. Choice B is wrong, like we mentioned already. The echocardiogram is not routinely performed in the initial evaluation unless there's indications of cardiac disease, as well as the urinary albumin-creatinine ratio can detect albuminuria, which is recognized as an independent risk factor for cardiovascular disease, but it's not routinely ordered during the initial evaluation. Choice D, like I mentioned, plasma renin activity, as well as aldosterone levels, is incorrect. There's no indication that this is going to be a primary hyperaldo state. And choice E, the renal ultrasound with MR, magnetic resonance angiogram of the renal arteries, is incorrect because there is no indication at this point to suspect renovascular hypertension is not part of the routine initial screening for primary hypertension. So what is the key learning point here? The initial evaluation of newly diagnosed hypertension evaluation aims to identify complications and comorbidities. It includes an ECG, CBC, TSH, serum chemistry panel, lipid panel, and UA to guide treatment decisions by assessing cardiovascular and metabolic health and risk factors.
Hey everyone, Chris here from MedPrep2Go, and I'm asking for your help. We are currently running a survey to better understand you, our audience. We're looking for feedback on the podcast, our Qbank, and to see what kind of content you would be interested in so we know how to best direct our efforts. The survey will be open until March 31st. We recognize that your time is valuable, so as a token of our appreciation, we're giving away 2 annual subscriptions to the podcast of your choice for winning participants. Just enter your email at the end of the form, and winners will be contacted in early April. Please take a few moments to help us out and complete the survey at medprep2go.com/survey. Thank you in advance. Hey everyone, Chris here from MedPrep2Go, and I wanted to ask you to please follow us on social. There may be links in the show notes, or you can find us at MedPrep2Go on Facebook, Instagram, LinkedIn, and now YouTube. We'd greatly appreciate it as we try to spread the word about MedPrep2Go and keep medical education accessible and affordable.
All right. I'm loving all these. Let's do one more today. Let's do this. 20-year-old woman presents to the physician with high blood pressure readings of 160/90, initially noted 3 days ago during a physical exam before starting a volunteer activity at a hospital. Her past medical history is negative. She has not taken any medications. She does not drink alcohol, smoke cigarettes, or use illicit substances. At this visit, her blood pressure is 160/85, and her other vitals are within normal limits. Body mass index is 25 on exam. A right carotid bruit is auscultated. Well, this is abnormal. A 20-year-old should not have a bruit. And she's hypertensive. ECG is normal. Blood test reveal normal chemistry panel, CBC, TSH, and lipid panel. Ooh, plasma renin activity is high. Aldosterone level is also high. And aldosterone-renin ratio is normal. So if you have a high renin and high aldosterone level, I mean, when do we see this? Is when there's decreased flow going from the renal arteries to the afferent arteriole. What can cause that? You nailed it, renal artery stenosis. And why would a 20-year-old get renal artery stenosis? Maybe it's from fibromuscular dysplasia, not atherosclerosis. And what really tips it to being, fibromuscular dysplasia? Nailed it, gender, and also that carotid bruit. So I don't know. I didn't even read the choices yet, but this is how I evaluate the question. I'm kind of pumped on fibromuscular dysplasia. So which of the following is the most appropriate next step in the evaluation? Do you folks want to get a 24-hour urine cortisol? No, thank you. This is not going to be a Cushing's type workup for a variety of reasons, physical exam. So A is wrong. B, adrenal venous sampling. Well, when do I do that? If I'm working up a Conn syndrome. And what will be the invasive gold standard for a Conn syndrome, whether it be determining if it's a one-gland adenoma or bilateral adrenal hyperplasia? Yeah, it's just adrenal venous sampling. But once again, this isn't Conn syndrome, and that's really invasive. So not B. C, check blood pressure again. You can never go with checking it a couple more times, but this has been going on for quite a while. And with the physical findings, I think you need to work it up. So C is wrong. D, check plasma fraction epinephrines. Does anyone think this is a FeO? It's not. Would FeOs give you the carotid bruit and that high renin activity? No, I'm not going to do that. And once again, if this was double back, if this was, a Conn syndrome, what would be the combo? It will actually give you, sure, a high aldosterone, but it'll give you a low renin. Can everyone say that? Low renin. So that's another reason why it's not going to be a Cons. E, well, you know what? I don't even want to read E because it's got to be the right answer. There's something left, but it's getting a CT angiogram of the abdomen. Of course, you want to look for that kind of stenotic type lesion, which is probably the right answer. And let me check. Oh, boom, it is E. And it says the patient's cardiac brewing, elevated blood pressure at a young age suggests fibromuscular dysplasia. FMD is a non-atherosclerotic and non-inflammatory disease affecting the arterial walls, leading to stenosis, aneurysms, and dissection. It typically affects women under the age of 50 and commonly involves the renal and internal carotid arteries. Clinical features include severe to resistant hypertension, particularly in young women, onset of hypertension before the age of 35, sudden increase in blood pressure, and an increase in creatinine levels after starting an ACE inhibitor. So classic. So if people don't understand why, you can imagine that when we talk about the glomerulus, it has the afferent, then efferent arterioles. So if you constrict the afferents, such as renal artery stenosis, GFR is definitely going to go down, get worse. But then if you give an ACE inhibitor, you're inhibiting angiotensin 2. Therefore, the efferent, it will dilate, further compromising GFR. They're further dropping the GFR. So if you get a sudden worsening of, GFR in someone who has bilateral renal artery stenosis after giving ACE, you got to think about something like fibromuscular dysplasia or even an atherosclerotic etiology of renal artery stenosis. Additional manifestations may include cerebrovascular symptoms such as transient ischemic attacks, strokes, and nonspecific symptoms like headaches and dizziness. In patients with suspected FMD, the diagnosis is confirmed by diagnostic imaging that reveals consistent findings. A non-invasive imaging test such as a CT angiogram is usually performed first. CT angiogram has strong diagnostic accuracies for FMD, including evaluation of those renal arteries. Invasive angiography is performed in patients if there's a high clinical suspicion of FMD, and the treatment with revascularization is planned if a stenotic lesion is found. A negative angiogram excludes a diagnosis of FMD in a vascular bed that was imaged. Of note, CT angiogram of the abdomen is used to diagnose FMD in the patient. She also should have imaging of her carotid arteries to evaluate the bruit heard on physical exam. Choice A, 24-hour urine cortisol, is incorrect. This is not Cushing syndrome. Choice B, adrenal venous sampling, is incorrect. This is not primary hyperaldo state, mainly because the renin and aldosterone levels did not correlate with someone with a primary hyperaldo state, which is high aldosterone but low renin. Choice C, checking the blood pressure again, is incorrect. Patient has physical findings that warrant a workup. Choice D, plasma fractionated metanephrine, is incorrect. This is not consistent with a pheochromocytoma. And the key learning point here is fibromuscular dysplasia is suggested by the early onset of hypertension, a carotid bruit, and high plasma renin and aldosterone levels. It often affects young women involving the renal arteries and carotid arteries. Approximately 75 to 80% of patients with FMD have involvement of the renal arteries. And they will also have involvement of the extracranial cerebrovascular arteries, such as the carotid and vertebral arteries. Approximately 2/3 of the patients have multiple arteries involved. Among adults, FMD is more common among females, and CT angiogram of the abdomen is the preferred diagnostic test of choice. So anyways, those are the 3 questions for USMLE Step 2 today. I hope everyone enjoyed it. If you want to get more awesome questions, please go to our website, medprep2go.com. And you want to learn more about me, check me out on social media, whether it's going to be Instagram or LinkedIn, or I can't believe I'm saying this, TikTok. And check out my book series published by Elsevier. It's Morning Report, Beyond the Pearls. I'm Dr. Raj, and I'll catch you again next time.
Hi everyone, Chris here from MedPrep2Go, and our friends at Panacea Financial have a scholarship opportunity for $1,000 for underrepresented residents and fellows. Applications are only open until March 20th, so submit yours today. Apply and learn more at panaceafinancial.com. Do you need a break from studying? Check out the Dr. Raj podcast, where he discusses topics such as wine with Jesse Katz, sarcoidosis with Bob Saget, saving the bees with Sydney S. Sill, and so much more. The podcast also features guest host Becca Spar, who focuses on leadership and connection, as well as Dr. Michelle Kulai and her Everyday Rooms segment, where she talks to patients to share their stories and the challenges that come with different conditions. Just search for the Dr. Raj podcast wherever you're listening now and tune in for a variety of great guests and topics.